Good morning, everybody, and welcome to the November 11th Grand Rounds. Feels like November out there. I guess that's because it is November out there. So this morning we have a fall conference showcase. Several of our scholars and resident physicians will be presenting to us this morning. I'd like to start out by thanking our sponsors, Bristol Myers Squibb and Novartis, who are out in the lobby. And of course, John Rickard, who's making sure everybody online has a great experience. And John's probably been here since 3:30. So thank you for John for always doing such a nice job. This morning, I'm going to ask Dr. Davide Margonato to lead off our presentations. Davide has been with us since 2023, had his medical school training in Milano, and is very much a great partner with the Valvular Heart Center and has an interest in tricuspid regurgitation. Davide is going to talk to us about association of regurgitant fraction and liver mapping analysis quantified by cardiac magnetic resonance with outcomes in patients with chronic tricuspid regurgitation. That's a mouthful. And you presented this at TCT, so thank you. Either one.
Our study. Can you hear me now? Okay, apologize. I thank MHF for the opportunity to present our study named Association of Regurgitant Fraction and Liver Mapping Analysis Quantified by Cardiac Magnetic Resonance with outcomes in patients with chronic tricuspid regurgitation. So the background of our study is that we know that chronic tricuspid regurgitation leads to right heart chambers remodeling and systemic venous congestion, affecting the outcomes regardless of any concomitant clinical context. This is why current European and American guidelines underscore the need and the importance of accurate TR quantification and of right side signs and symptoms of heart failure to determine the best time for invasive treatment of tricuspid regurgitation. We also know that in the last year, CMR has emerged as a valuable method to appropriately quantify tricuspid regurgitation as well as its cardiac and extracardiac consequences. However, there are still some unanswered questions and open problems. In particular, whether TR regurgitant fraction and regurgitant volume, how they associate with outcomes is really poorly defined. There are really small literature published on this topic. And moreover, whether beyond TR quantification, novel CMR parameter can appropriately assess the cardiac and extracardiac consequences of TR is unknown. So therefore, we aim to assess first, CMR-based TR threshold associated with long-term outcomes, and moreover, whether a novel parametric biomarker called liver extracellular volume, so a marker of both fibrosis and systemic venous congestion, could increment risk stratification in this patient population. Therefore, we collected data on patients evaluated with CMR at our center. This is basically an all-comers cohort, so we only excluded patients with more than mild concomitant pulmonary regurgitation, with concomitant severe left-sided valvular disease, and with competing risk for non-cardiovascular death. As you can see, a very limited number of patients excluded, so again, an all-comers cohort, finally including 489 patients. The primary outcome of interest was the composite of all-cause death and heart failure hospitalization under medical management, therefore censoring follow-up at the moment of tricuspid valvular intervention. For the purpose of this study, we focus our attention on regurgitant fraction, which was measured, as you can see, by obtaining the RV stroke volume, as you can see in the left side of the images, by measuring end diastolic and then systolic volume of the right ventricle, and by phase contrast imaging, which you can see on the right part of the images, which allowed us to measure the pulmonary forward stroke volume. Therefore, regurgitant volume was obtained by removing PA stroke volume from RV stroke volume, and regurgitant fraction then by dividing the R volume by the RV stroke, regurgitant volume by the RV stroke volume. For the secondary analysis on liver ECV, here you can see an example of this measurement. a patient with mild TR. You can see in blue the appearance of the liver parenchyma and the region of interest. This is a very fast and straightforward measurement. On the right, you can see an example of a patient with severe TR and increased liver ECV. When tracing the region of interest, we only have to be careful at not going away from the large congested vessel, which would increase the extracellular value. For this secondary analysis, we just excluded patient without mapping analysis at the moment of CMR evaluation and with concomitant organic liver disease, therefore finally including 371 patients. So this is just to briefly show you the baseline characteristic of the population. As you can see, median age 68 years old, roughly 1/5 with advanced NIA class symptoms, median TRI score 2, so generally a low-risk patient population. And as you can see on the right part, the median regurgitant fraction was 21%, so we included patients with different grade of TR severity. So after a median follow-up of 2.3 years, 9% of patients died and 30% were hospitalized because of heart failure. And here you can see a restricted spline curve model associating the regurgitant fraction with the hazard ratio of having the primary composite outcome. And you can see that the threshold associated with the outcome with a hazard ratio greater than 1, along with the whole confidence interval here represented in gray, is a regurgitant fraction cutoff greater or equal than 30%, so way lower than the currently suggested by guidelines to define severe TR, which is 50%. So when dividing the population according to this cutoff, you can see that there is a marked separation of the two curves in terms of long-term outcome. You can see on red patient with regurgitant fraction less than 30%, in blue patient with regurgitant fraction greater or equal than 30%. So a wide and maintained throughout follow-up separation of the curves. So when looking at hierarchical adjustment model to see the independent association of this cutoff with outcome, you can see that in a first model adjusted on age and gender, in a second model including the first plus major comorbidities, as well as in a third model including the second plus biventricular ejection fraction and pulmonary pressure, this cutoff remains significantly associated with the outcome of interest. So as for the secondary analysis, this is a restricted spline curve showing the association with liver extracellular volume with the hazard ratio of the primary composite outcome. Again, the threshold here associated with the hazard ratio greater than 1 along with the whole confidence interval is greater or equal than 32%. And this to briefly show you how this cutoff really captured the presence of right heart failure as a consequence of TR, because you can see that when evaluating the variables of interest associated with right heart failure, the clinical, the echocardiographic, and the CMR variables, they were all significantly different and worse in patients with liver extracellular volume greater or equal than 32%. And finally, this presented incremental risk stratification because here we divided the population in 4 groups according to the regurgitant fraction cutoff and the liver extracellular volume cutoff. And you can see that patients with increase of both regurgitant fraction and liver extracellular volume represented in the blue line had by far the worst long-term outcomes compared to patients without the increase of both values. So in conclusion, in a large cohort of all comers, patients with tricuspid regurgitation with different grade of TR severity, we identified a novel cutoff of TRF associated with long-term outcome. This cutoff was associated in different adjustment model and is way lower than the one currently suggested by guidelines to define severe TR, which is 50%, mostly derived from the experience on left-sided valvular disease. And finally, we proposed this novel biomarker, which is liver extracellular volume, that in our study captured the presence of right heart failure as a consequence of TR and provided increased risk stratification in this cohort. And thank you for the attention.
Thank you, Davide.
Does anyone, any questions from Jay?
Thanks for that great talk. I was just curious if you, sometimes like in some of our post-surgical patients, after bypass, some of them get acute, right-sided heart failure, and they all seem to get liver elevations in their liver transaminases and everything. And I'm just wondering, did you look at any of these patients' labs to see if there's any association between elevated transaminases and maybe extracellular liver volume, etc.?
That's a great question. Actually, we had in the small population that underwent tricuspid valve intervention, we didn't look at the change in lab values in terms of hepatic function. What we would like theoretically do by increasing the cohort, of course, is to see if liver ECV itself would change after treatment in terms of a decrease of the value after TR treatment, whether it's surgical or percutaneous. We didn't specifically look at the lab values, only just a small part of the cohort underwent tricuspid valve treatment. But what we would ideally do for the future is to look at the change in liver ECV after treatment.
What are your thoughts about the therapeutic implications of your findings?
Thank you for this question. Well, the idea behind this finding is to capture with CMR the presence of TR consequences before the patient could develop symptoms, right heart marker signs and symptoms of right heart failure. So the idea is to identify patient at the right moment to start addressing to eventual invasive, whether surgical or percutaneous treatment. So the idea behind this is when is the best time for treat this patient? What CMR beyond TR quantification how can it help us to identify the best time for treatment? So we believe that with a regurgitant fraction cutoff way lower than the 50%, this is already associated with outcomes. So define severe TR early, what is currently done, plus look at liver ECV to see patient that can become really a high risk of surgical particular, but maybe even interventional therapeutic. So let's start to address this patient for treatment way earlier than what is currently suggested.
Thank you very much. That was very interesting. Our next speaker is Dr. Pedro Carvalho from the Center for Coronary Artery Disease. Pedro just joined us recently this year and has already distinguished himself with his work with Dr. Sandoval and Dr. Berlakis, and his interest in both CT and PCI, and also in acute myocardial infarction in general. Pedro hails from Brazil, and he's going to speak to us this morning on coronary computed tomography angiography for percutaneous coronary intervention, the initial United States experience with FFRCT-based virtual PCI, sort of related to the conference that was just held here last month.
Hear me okay? So thanks, Dr. Sharkey, for the introduction. So my name is Pedro Carvalho. I'm a research fellow at the Center for Coronary Artery Disease. I've been working with Dr. Berlakis and Dr. Sandoval, and today I will present our the first experience in the United States using FFRCT-based virtual PCI to perform a pre-procedural planning of the percutaneous coronary intervention. I have nothing to disclose. So advancements in coronary imaging have allowed us to analyze not only the coronary anatomy, but also the coronary physiology, particularly when we use the coronary CT to do so. But most of the times we only use the CT data to pretty much rule in and rule out patients with coronary artery disease. But we have a powerful tool with the CT. So we can also use this data to perform a pre-procedural planning before even sending the patient to the cath lab. However, we don't have enough data to support this approach. So it's not changing. So we performed an observational and single center study analyzing our initial experience with FFRCT-based virtual PCI, and we have included patients, adult patients, with at least one vessel with an FFRCT lower than 0.80, and patients without STEMI. So we did the pre-procedural planning in all these patients. And here, I know these concepts, they are kind of tricky to grasp at first, so I will try to show this using a clinical case. So this is a This is one of our live case in the last city-guided PCI course. So we had an 80-year-old male suffering with dyspnea, and he underwent a coronary CT showing severe disease in the LAD. So most of the times, this patient would just go for the cath lab and see the angiogram, and we will decide whether or not to do the PCI. But as we have this information from the CT, we can do a pre-procedural planning without even sending the patient to the cath lab. So we can have a lot of information from the CT. So one of the information we can have from the CT is the MIP, the maximum intensive projection. That's pretty much a 3D model of the coronary tree, and we can pretty much see the vessel tortuosity and disease severity. So in the cath lab, we have only the angiogram, so we have a two-dimensional view. And here we have a 3D view, which is very informative. And based on this, we can, for example, select when the patient will do this case. For example, we have a very calcified disease in the LAD. So this patient might need a calcium modification strategy with a surgical background. You will not want to do this in an ambulatory setting, for example. So just with this image, we have a lot of information. Another information we can have is using actual views to see the coronary ostium position. And this is very important to do the catheter size selection. And especially when the patient has anomalous takeoffs of the coronary, you might need to select a different catheter in these cases. Another information we can have from the CT is the MIP, it's the multiplanar reconstruction. And here we can have, we can assess especially the play characterization. And in this case, as you can see, we have a severe calcification. And in the cross-sectional views, we can also see this severe calcification in this coronary artery disease. Another tool that is very important, as you can see at the left, we are going up and down. It's pretty much, you can measure the length of the disease. And this is helpful for the stent sizing selection, especially because when you land the stent, you want to land this in healthy areas. So you have to try to avoid to land the stent in a region with a plaque. So this is very important for stent size selection, for example. Another information we can have from the CT, as you can see here in this arrow, we can see, for example, the optimal fluoroscopic angles. As I said, you can help with the stent size selection. In this case, as the arrow is pointing, it's like 34 millimeters. And another very important characteristic that we can take from the CT is the physiology. So we can have access to the FFR derived from the CT without putting a pressure wire in the patient. So for those who don't know, the FFR, it's basically a physiological measurement. And when it's lower than 0.80, this is considered a significant disease. And in this case, as we can see, we have a significant disease in the LAD with an FFR of 0.73. And to have this information many years ago, we would need to put a pressure wire in the coronary. And here we can have this without sending the patient to the cath lab. Before even having the patient in the cath lab, we can have access to this physiological information. And another important feature is that we can drop a lot of points throughout the vessel and see whether or not this is a focal versus diffuse disease doing a virtual FFRCT pullback. And especially in our case, which was very important, it was to use the FFRCT-based virtual PCI to drop a stent in this lesion and see what would be the predicted post-PCI FFR. And the post-PCI FFR, it's a predictor of MACE and target vessel failure over the years. So we can, for example, drop different stent lengths. For example, with 18 millimeters, we would have a suboptimal FFR of 0.81. But if we put a longer stent, for example, with a 38 millimeters, we would have a better post-PCI FFR. So we decided the stent length based on all these characteristics. And we have a lot of vendors integrating all this information, but we have for example, HeartFlow is trying to integrate all this in one product, which is really important as well. So we performed the standard statistical analysis. We use the peer correlation analysis and Blend-Altman method to assess the agreement between different FFR modalities and the stent sizing. And here are our results. In our cohort, we have included 48 patients with a mean age of 70 years old. Around 40% were women, and most of the patients, they were admitted with chronic coronary artery disease. Regarding the CT data, the median calcium score was 609. 70% of the patients received beta blockers, and all patients received optimal doses of nitrates, leading to high quality images. And the LAD was a target vessel in most of the cases. And here are our results in hospital results. And so we have all patients achieved technical success. Most of the patients, they were discharged on the same day or one day after the procedure. In our cohort, all patients also underwent intravascular imaging to help in the stent sizing. Most of them received IVAs. And another very important feature in our cohort is that almost 25% of the patients received calcium modification strategies, showing that the CT can analyze calcium way better than other modalities. And as predicted by the CT, the LAD was the main target vessel in most of the cases. So here we have a correlation between the FFRCT and the invasive FFR methods using either pressure-aware FFR and FFR angio. So in the x-axis, we have the FFRCT. In the y-axis, we have the FFR or FFR angio. And as you can see, we have a strong correlation between these two methods with a mean difference of only 0.01, which means that what we can predict using the FFRCT planner, we can really observe this in real life when we send the patient to the cath lab, which is really important. We also performed a subgroup analysis using the FFRCT versus FFR angio exclusively, which means that we are analyzing two modalities without using a pressure wire, so wireless physiology methods. And we also had a good correlation and with a mean difference of minus 0.01. And regarding the stent length, in the x-axis, we have the planned stent length according to the virtual PCI planning. And in the y-axis, we have the actually used stent length in the cath lab. And in our cohort, we also use intravascular imaging. So this shows that the stent length agreed between what we planned with the virtual PCI versus what we actually use in the cath lab with a mean difference of only 2 millimeters. So this study has limitations. This is a small and observational study in a single center, and we have a modest sample size. So in conclusion, the FFRCT-based virtual PCI was associated with excellent in-hospital and follow-up clinical endpoints. The FFRCT had a good agreement with other invasive FFR methods. Around 25% of the patients in our cohort received advanced calcium modification strategies. And of course, we need more data. We need more prospective multi-center studies and even RCTs to analyze the impact of the pre-procedural planning using the CT to perform a PCI. Thank you so much.
Thank you very much for that great presentation. Questions?
Excellent work. Thank you, sir. Great presentation. Thank you. One question I have is FFRCT versus invasive FFR. What variables get into the FFRCT in terms of, like, you said it's very comparable compared to the invasive FFR. If you could tell us more how the FFRCT is calculated, that would be great. Thank you.
So this is a good point, but this is a lot of mathematics. I don't know how to explain exactly, but it's pretty much when you do the coronary CT, you have to put a contrast and a dye in the coronary artery, and based on the flow you have on the CT, you can use computational mathematics. It's really tricky, but it's proven to be right. So it's pretty much this.
Thanks.
The LAD seemed to be overrepresented in this cohort, and thoughts on whether your findings are applicable to the other coronary
arteries and distal vessels and things like that?
Yeah, so the LAD is the target vessel. In any study we can analyze most of the cases the LAD, but here we have like a huge representation of the LAD. And of course, I agree this is a limitation, and we need more data for the vessels as well. Yeah.
Anything online, John?
Nothing online yet.
Thank you very much, and good luck with the rest of your studies on this. It's an exciting new area.
Thank you so much.
I forgot to mention that Dr. Carvalho is the inaugural Butch Ames and Barbara Thorndike scholar. They have been very, very, very generous supporters of MHIF, and so we thank them for supporting Dr. Carvalho's work. Next, I'll invite Dr. Hayley Turch to the podium. Dr. Turch is a third-year resident with us at Abbott Northwestern Hospital, and hails from the University of St. Thomas, where her undergraduate was done, and Des Moines, where her medical school was. And she has an interest in women's health and prevention, and she's worked with Dr. Saxena on peripartum cardiomyopathy, and also I think with Dr. Miedema in prevention, but her presentation today is going to be on understanding peripartum cardiomyopathy care continuum within the Allina health system. So welcome, Hayley.
Hello, everyone. Thank you for having me today. I'm going to be talking a little bit about peripartum cardiomyopathy and what that looks like here at the Allina health system. I will like to start off kind of just overviewing what peripartum cardiomyopathy is. I have the diagnostic criteria here listed, and I'd just like to highlight that peripartum cardiomyopathy, one of the diagnostic criteria is an LVEF equal to or less than 45. Within that peripartum period and without any other identifiable cause of heart failure. So recognizing that's kind of vague. And then just kind of looking a bit about epidemiology, the incidence is 1 in 2,000 pregnancies worldwide, but recognizing that there are regional differences based on different areas, specifically Nigerian women and Haitian women have a higher incidence of having this. It's the leading cause of maternal death and 4 times as likely to develop in Black women versus white women in the United States particularly, and Black women are 2 times more likely versus white women to have a persistently decreased LVEF. Again, the pathogenesis of peripartum cardiomyopathy is poorly understood. I've included a graph from the New England Journal article published in January of this year that talks about some of the physiology during pregnancy and how it maybe relates temporarily to different hormonal changes. I'd like to point out the prolactin association as well as the FLT1 or the soluble FMS like tyrosine kinase 1 hormone and how those may be associated with peripartum cardiomyopathy. And we also know that maybe there's this genetic component to peripartum cardiomyopathy as well. Recognizing that maybe this is within a spectrum of non-ischemic cardiomyopathy as well. I've listed a couple of risk factors here for developing peripartum cardiomyopathy, but again, I think it's a little vague because we don't fully understand the pathogenesis. And again, peripartum cardiomyopathy can be hard to diagnose, as I alluded to, and I'd like to point out kind of different things that it may be when you're looking at somebody who is presenting with decompensated heart failure during their pregnancy, specifically looking at different causes of other underlying cardiomyopathies. And then also I'd like to recognize kind of the hypertensive disorders during pregnancy that can mimic what peripartum cardiomyopathy looks like. To treat peripartum cardiomyopathy, we do use our goal-directed medical therapy that we derive from heart failure with reduced ejection fraction. But also there are two other considerations, bromocriptine, which is used in an LVEF less than 35 to suppress prolactin, as well as some anticoagulation to prevent LV thrombus. And then managing peripartum cardiomyopathy long-term takes a lot of kind of interdisciplinary work in counseling regarding contraception, recurrence, and especially lactation when we're looking at these medications in pregnant persons or breastfeeding persons. So we partnered, our Dr. Saxena and I and our colleagues are looking at what this looks like here. So we sought to evaluate the current state of peripartum cardiomyopathy within the Allina health system. And we looked to all of these cases that were flagged were people presenting or women presenting with peripartum cardiomyopathy like decompensated heart failure symptoms. And we sought to characterize these patients and assess whether they are appropriately managed. So to do that, we looked at retrospective chart review. We looked at what they were doing and what they had preconception, during pregnancy, during delivery, and after and postpartum within that 6-month period, although technically there's maybe a 5-month period is what's defined in peripartum cardiomyopathy. So we looked at different demographics, different pre-existing comorbidities and medication use, both during preconception and through the peripartum period. And then we also looked at follow-up appointments during pregnancy and postpartum, and then looking at different complications that occurred during their course. And part of that was looking at different diagnostic criteria, as shown at the bottom of this slide. So here are some of the demographics of the patients that we saw within our chart review. Looking at the mother's age of delivery, an average of 30 years old, which kind of reflects, again, some of those risk factors that were shown earlier. 30 years is actually defined as advanced maternal age. And then we also looked at different race of the population, and I'd like to point out that 28% of the women were Black or African American, which accurately kind of reflects the 4 times as more likely diagnosis that I alluded to earlier. I looked at the 2020 census of Minnesota, and 7% of our population was Black, so it actually directly kind of reflects that. And then I'd also like to just kind of allude or point out the pre-existing conditions, which are, again, some of those risk factors. And then kind of across the board, a gestational history, no kind of preference one way or the other, despite having higher risk with more pregnancies. So looking at kind of our cohort, here is the number of patients who truly did have peripartum cardiomyopathy through the adjudication process. It was 39.1%, but the majority were not technically peripartum cardiomyopathy in our study. And of those the 61.9% who were not technically peripartum cardiomyopathy, the majority of them were women with preeclampsia, and then secondly, women with heart failure with preserved ejection fraction. Again, there were some unknown, and some of those other kind of differentials were included in those women who did not have peripartum cardiomyopathy. So here on the left, we have just kind of a density graph of the ejection fraction within the women included in this study, and seeing that a lot of that is tailored toward the right side, or a higher ejection fraction, which kind of reflects the fact that the majority of the women in this study did not have peripartum cardiomyopathy, or that LVF equal to less than 45. And again, this is reflected differently on the right side of the slide with just kind of a dot plot looking at those different ejection fractions. Looking at diagnostic kind of clues to peripartum cardiomyopathy, where there's a question whether BNP can be used to kind of clue us into whether this is peripartum cardiomyopathy. And the data isn't clear. There's no clear, anyway, it's not clear. So on the left, we have a graph looking at the EF and the BNP. And in our study, we do see that the women who have a lower EF, and those who do have peripartum cardiomyopathy have a higher BNP. On the right is just showing the pro-BNP, recognizing that the number of women who did have a pro-BNP in our study was a little bit lower, but also reflected the similar findings of having a higher pro-BNP with a lower EF. And then looking at management of these women, like I said, the management is goal-directed medical therapy, similar to HFrEF, and 100% of them were on a beta blocker, and then the second most was ACEs and ARBs, and I think that is reflective of the hypertensive nature of peripartum cardiomyopathy and the spectrum kind of maybe that it may have with preeclampsia. SGLT2s are low, and that's just recognizing that there's not enough safety data during pregnancy or lactation to recommend that. And then looking here, this is just kind of, again, saying that a lot of these women have this hypertensive spectrum, and that's how they're not best treated, we're most treated. And then one of the things we did look at was following up with cardiology and with MFM and other office visits, and we saw that the women who were following up more with cardiologists were not more likely, but just were more on GDMT. So again, I'd like to just kind of round this out saying that peripartum cardiomyopathy is often misdiagnosed, recognizing that that LVEF of 45 is part of the diagnostic criteria, but that leaves kind of the door wide open for other things that it also could be. And then most patients with an accurate peripartum cardiomyopathy diagnosis received goal-directed medical therapy, and primarily that was with antihypertensives, recognizing that the association with preeclampsia and high blood pressure within the physiology of it. And then follow-up with cardiology is crucial for ensuring the initiation and maintenance of GDMT. And I'd like to just round out this talk talking about kind of the next steps with this project and peripartum management moving forward. I've talked a little bit about the preeclampsia and the increased incidence of patients that had that were presenting with decompensated heart failure, and recognizing that we have a lot of focus on the peripartum management, but there are still women that are presenting with pulmonary edema and other signs of heart failure that we don't know exactly what to do with, and recognizing that there is still more work to be done, not only within peripartum cardiomyopathy, but within peripartum heart conditions in general. And then another thing that we are looking forward to doing is genetic testing, not only in those with peripartum cardiomyopathy, but some of the other patients without too, recognizing that this may be a spectrum of disease. And then two fun things that are coming to MHI here is the Rebirth trial and looking at bromocriptine and recovery and LVEF, and also the HOPE study, which is the Heart Outcomes in Pregnancy Expectations study, and looking at pregnant persons with cardiovascular disease and their outcomes. And this is at a bunch of centers across the US. So thank you all for having me today.
Thank you very much, Hayley. Any questions from Dr. Travers?
Thanks for that great talk. If you exclude women who develop preeclampsia or have severe hypertension, is pregnancy capable of causing a cardiomyopathy itself, or do you think all these women have pre-existing cardiomyopathy going into pregnancy and it just becomes manifest due to the hemodynamic load of pregnancy?
I don't think we know for sure, but I think there is the possibility that women who don't have pre-existing cardiomyopathy can still develop a cardiomyopathy for other of these hormonal changes that maybe aren't necessarily meeting the criteria for peripartum cardiomyopathy, or having a differential for those other things in that slide. I think there's just a lot of unknown.
Hayley, great presentation data. I was wondering if you had some information about the longitudinal changes of ejection fraction, because that might be also, along with what Dr. Travers mentioned, is this a manifestation of just the environment of what's going on, and how does it track along after the pregnancy too?
Yeah, that's a good question. I don't know if we have that data.
We have the data, we haven't looked at it, but that's a good
Okay.
idea. So
Yeah.
we'll have to do that. It's in
Got
there.
Excuse me.
Great presentation, thank you. In the setting of a misdiagnosis here, I think when the peripartum cardiomyopathy is misdiagnosed, I think is, as you clearly described, is overrepresented, and then later on, like it's either preeclampsia or hypertension. Would you say in this case it might be a good thing that is misdiagnosed? That way, these patients will get more cardiology and maternal fetal care. That way, we can later on kind of like specify what specifically is the cause.
I'm just going to repeat your question to make sure I understood. Are you asking if it's maybe like a good thing that the women who don't have peripartum cardiomyopathy are diagnosed?
Yeah.
Okay. Yeah, I think it's hard because I think maybe women who don't exactly have a peripartum cardiomyopathy diagnosis may not be followed as closely as those who do. So I might actually kind of twist that and say maybe it's not a good thing that they don't technically have this diagnosis because they aren't getting that longitudinal care.
I have one last question. What?
Can I
what-
add to that, Scott, real quick?
Oh, sorry.
That's okay. So we have that data, we just didn't present it. We actually do worse in the individuals who presented with heart failure who don't walk away with a true diagnosis of peripartum cardiomyopathy. Our follow-up tends to track EF, so the lower your EF, the more likely you are to get followed. But there is data out there that shows that individuals who present this way in the peripartum period with a preserved ejection fraction, with whether it be preeclampsia or just maladaptation to the fluid challenges and boluses of pregnancy, that they do not do better long term. So these women end up coming back within about 10 years with their first diagnosis of heart failure postpartum. And so I think it is important, your point. I wouldn't call it misdiagnosis. I think the big thing is looking at this as a continuum of heart failure and pregnancy. We get so fixated on peripartum cardiomyopathy, but I think what we're missing is the maladaptation to the cardiometabolic unwellness, whether their EF was normal or not to begin with in the prepartum state.
Sort of a follow-up to the questions. How do we know that traditional guideline-directed medical therapy is really effective in this particular population? What do we know about that?
I see Dr. Saxena raising her hand.
No, it's very exciting, right? So that's it's very exciting. You know, the problem is we haven't studied these women, right, for decades. So Rebirth is going to try to help answer that. Rebirth has a cohort of women who aren't getting bromocriptine, as well as there is a look at. You know, we haven't looked at bromocriptine in the setting of GDMT, right? So if you remember, the bromocriptine trials are all very old. Bromocriptine isn't usually used here in the United States as much as it is. There's a really nice study, and I don't know that Hayley put it up there, looking at 10-year outcome in true PPCM. And we do know that there is an uptrend towards doing poorly, even with recovered EF. And so I think it goes back to Jay's initial question. Are these individuals just genetically predisposed to having a cardiomyopathy that's then unmasked by the hormonal milieu and plus or minus hypertension? Because not everybody with PPCM has preeclampsia, but lots of preeclamptics have PPCM. And so I think it's more news to come. But I know that the people that follow these women, if there's no recovery, we keep them on. If there is recovery, the recommendation is you stop. You relook at 3 months, you relook at 6 months before you say, okay, yeah, you're fully recovered. So not all of them recover, and not all of them, do we stop GDMT? As Hayley says, the data is still out.
And do you counsel them not to get pregnant again?
Depends on EF recovery. So if the LVEF gets above 50% off GDMT, stays above 50% off GDMT, the risk of recovery and subsequent pregnancy is 20%. That's the relapse risk. But gravity and mortality is pretty low. If your EF is below that 50%, your risk of relapse is about 40%. and 40 to 50, and the chance of you decompensating is very, very high. We do recommend that everybody who's had PPCM or heart failure in pregnancy be managed in subsequent pregnancies in a multidisciplinary fashion, and that's what HOPE is hopefully going to answer to.
A lot of interest in your topic. Thank you very much. And our last presentation is by Dr. Asa Pichapop, who hails from Thailand. He's an interventional cardiologist, has been with us for a long time, and has, you have, and we wanted you to stay longer. Has done a great job in working with imaging Dr. Cavalcanti and his group in valvular heart disease. And I'm going to invite Asa to come up and talk to us about the feasibility of CT as a gatekeeper for invasive angiography decision-making in TAVR patients.
Thank you very much, Dr. Chaki, for your kind introduction. And hello, everyone. My talk today will be about severe aortic stenosis patient undergoing transcatheter aortic valve replacement or TAVR. Can we use the CT scan to determine the coronary artery stenosis and to exclude significant stenosis instead of using the invasive coronary angiography? So two important background. Okay. Yeah. So two important background here is that the guideline recommendation for the patient who will be undergoing TAVR to have coronary artery evaluation before the procedure. And historically, it was evaluated by invasive coronary angiography. So due to every patient here, they needs the CTA to evaluate the aortic stenosis before the procedure. So we call it TAVR CT. So can we leverage that data to look for the coronary artery stenosis instead of routinely send the patient for invasive coronary angiography? Because we know that the coronary CTA, especially the dedicated coronary CTA, they have high negative predictive value in excluding significant coronary artery disease for the patient who present with chest pain. And also, those dedicated coronary CTA have the beta blocker and sublingual nitroglycerin, as Pedro mentioned before, to have the good quality image. But from the TAVR CT, we don't routinely pre-medication those patients because aortic stenosis may have risk of decompensation of the pre-medication. So there was some study that matched between the CT and the coronary angiography and say that the diagnostic accuracy is good, but how safe it is. And the clinical application in the clinical practice for this approach have not been demonstrated. We know that when we match the CT comparing to the invasive angiography, even without pre-medication, there was high sensitivity of 95% and moderate specificity of 65%. That is because CT also have the limitation. On the right picture here, when there are heavy calcification, CT is limited when we want to evaluate how the stenosis degree is. Comparing to the less calcification, the CT is more accurate on saying that the patient don't have any stenosis or how many percentage of that. So what we want to know the ability of using standard pre-TAVR CTA protocol without pre-medication to be a screening tool for rule out obstructive CAD, and we want to compare the outcome after TAVR between those approach. And in the patient who has both CTA and invasive angio, we want to match to see how it's accurate. And also finding the factor of the patient who has increased needs for invasive angiography. In our center, the prevalence of the CAD is about half and stable during this 6th year. But the routine invasive angiography before TAVR is decreasing due to the COVID era that we try to find the alternative way to expedite pre-TAVR workup and using the CT scan to try to exclude CAD. So the prevalence of the percentage patient having invasive angiography decreased from about 95% to 50%. The inclusion criteria here, the important thing is that we use the TAVR CTA with 0.6 millimeter thickness and evaluate at the systolic reconstruction. We exclude cabbage patient, and the outcome we want to see the coronary-related event up to 1 year after TAVR. Regarding the coronary revascularization, acute coronary syndrome, and unplanned invasive angiography. From 1,400 patients who underwent TAVR over this 6 years after exclusion, 464 patients have the coronary evaluation for proximal segment stenosis by TAVR CTA, and 700 patients have coronary evaluation by invasive angiography, and we see the outcome up to 1 year. This is the result of the baseline patient between groups. Both characteristic is comparable. Age, median age about 81 years old, 53% of male, and those two groups fall into low risk of the STS score with a little bit higher for the invasive angiography arm. This is the baseline characteristic of the CAD. Obstructive CAD here is about 40% because we exclude the cabbage patient. And the pre-TAVR angiography was done in TAVR CTA group about half of all patients. And the pre-TAVR PCI is less than 20% in both groups. When we compare the ratio between the patient who has PCI performed by the all angiography done, because angiography was already selected from TAVR CTA, so the ratio of the PCI is like select the patient who has increased risk of having PCI performed. So it's 30% of the patient in TAVR CTA have PCI performed, comparing to 20% in invasive angiography groups that we do the coronary angiography in all patients. This is the result at 1 year. The symptom-related revascularization is low in both groups. It's 1.8% in invasive angiography groups, comparing to 0.8% in TAVR CTA group, which were low and comparable. The result of the acute coronary syndrome in invasive angiography group is 1.7%, comparing to the TAVR CTA group is 1.6%. Again, there's no significantly different. Then the unplanned angiography here is also low. It's 2.8% in invasive angiography group, comparing to 2.7% in TAVR CTA groups. So those three outcomes were low in both groups and comparable. So it's quite safe up to 1 year to use the CTA as the gatekeeper. When we look into the subgroup of the patient, 464 that has TAVR CTA evaluation. The green box here, TAVR CTA did not suspect any obstruction of the CAD in up to 2/3 of overall patient. And then skip angiography was proposed to the heart team. On the pink box in the below, TAVR CTA could not exclude CAD or suspect the CAD in 1/3 of the patient, and those patients was sent to subsequent invasive angiography performed. On the yellow box here is the patient who already exclude CAD from the CTA, but the physician decide to undergo invasive angiography, which is mainly like during the transitional area, and in some cases that is the preference case by case. So when we look at the factor which patient will require invasive angiography after CTA evaluation, we have two factors here. One factor is male gender have increased need for invasive angiography for 1.5 times. And another one is the history of PCI increased needs for invasive angiography 2 times higher. There was some patient who has both CT and subsequent invasive angio, so we try to match that and say how accurate of the CTA. We got a sensitivity here of 88.5%, specificity is 75%, which is quite moderate. And of noted that negative predictive value is 91%, which is quite high. but the important thing is that TAVR CTA did not miss any left main or proximal LAD stenosis, which is the very crucial vessel segment. The most common segment that the CT will misinterpret as underread would be the proximal RCA. So for the conclusion here, when we use the TAVR CTA to evaluate CAD in those who will be going for TAVR, comparing to invasive angiography, the pre-TAVR CTA evaluation of the coronary artery disease can safely exclude those significant CAD up to 2/3 of overall patients without missing the proximal LAD or severe left main disease, while they maintain the comparable low incidence of the coronary-related event up to 1 year after TAVR and is equal to conventional invasive angiography. And they provide a reassuring with high negative predictive value. And we also noted that male patient and patient with history of PCI has increased needs for invasive angiography after TAVR. Thank you.
Thank you, Asa. Do we have any questions?
Do you think that given the additional medications could improve even further the yield of the assessment? Is this something that we should try to think about in our group as well? Or are we good as we have as it is?
Yeah, thank you. I think that's a very important question. So there were studies presented in TCT that they used the pre-medication, the beta blocker, and sublingual nitroglycerin in the quite big population. It's about 400 of the patient, and they said that the side effect or the adverse event of giving that medication is very low. It's like only like 1% or less. So it means because theoretically we a little bit concerned in those severe AS to pre-medication them, but after the study, I think it's possible with good monitoring. Like if we have good patient monitoring and give the pre-medication, I think it will increase the capability of the CT, because when heart rate is lower, we can see the coronary artery more clearly, and also if the nitroglycerin have been given with the vasodilatory effect, it would help. I think it would help with excluding those patients.
Very nice presentation. Can you speak again a little bit more about how many of these patients had FFRCT and your perspectives on that, at least in the cath lab, in patients with severe aortic stenosis. There's been, as you know, some data suggesting that non-hyperemic pressure ratios may be a little bit more reliable than FFR, particularly with some of the FFR changes surrounding, aortic stenosis and what happens pre and post TAVR. So I'm just curious about that.
Thank you so much. I think it's a very important question. So I also talked to the representative of the FFRCT about the possibility of having those scans to analyze for FFRCT. The problem that they have from previously they attempt to do that is that this was not given pre-medication, and more than half of them have been declined as inaccurate, or the scan quality that they got is not enough to perform the analysis of the FFRCT. So I would say in this our cohort we don't have the FFRCT performed in those patients. And also another thing added to that, they have the presentation in TCT as well that they try to use the FFRCT in this patient, but those patients have pre-medication, beta blocker, sublingual nitroglycerin in order to optimize the quality. So I would say the future of this study is to try to use the FFRCT and try to use the pre-medication with good monitoring. Then we can have more patients to exclude for significant CAD. So now we have about 2/3, and I think we can have more.
We have one online question for you.
We do. Thank you, Asa, for that great talk. This is a comment from Dr. Lesser, and he says patients with known disease in the TAVR CT group included those with prior PCI as opposed to prior studies where they were excluded. He goes on to say, I might add that experienced readers can accurately exclude non-CABG patients who will not need invasive angiography.
Thank you for the question. Yeah, that's very important because when we first do this project, we try to exclude all the patients with prior PCI. So we want to select the clean cohort that they do not have any PCI, do not have any CABG, or very clean. But then later we extend the cohort to include those with stent. So the patient with stent also include in here. And we see that some of them CT can say that stent is patent. But go back to the factor that associated with the increased need for invasive angiography. You see that patients with history of PCI have 2 times higher chance of requiring invasive angiography after CT evaluation. That means we can our center can exclude that, but for bigger proportion of the patient with history PCI, they would need the subsequent invasive angiography to be accurately exclude the CAD.
Thank you, Asa. Thanks to each of the presenters for a great morning education.